I do see a clustering of questions essentially around what to do next. And I'll start with the question of what chemo regimen is best once you've run out of targeted therapy.
So, I think it depends a little bit on what prior treatment patients have had. For patients who have not had any chemotherapy, which is often the case, if we find an EGFR mutation when we start, the patients will go on to the TKIs and haven't had any chemotherapy types of treatments. And for those patients, I think carboplatin and pemetrexed, or Alimta, being the other name for pemetrexed, is my preferred approach. It's a chemo regimen that's given once every 3 weeks. I have found that generally it's fairly well tolerated, although for most patients they can feel well on it. They don't have to come to clinic too often, and that is my preferred approach. How about yourself, Jared?
So, I talk to my patients about two basic regimens, and I will confess between you, me, and whoever happens to be listening to us here that I'm rooting for a pemetrexed-based regimen as well, because it's just more humane. Everyone's afraid of chemo. Everyone hates chemo. I hate chemo. I know you hate chemo because you're nodding, and we've talked about it. Our patients hate chemo. We can't ignore two things. First is that our cancer is awful. And that chemo, while it does create suffering, also can prevent or roll back suffering. And we can never ignore either, so we have to weigh them. And we also can't ignore that not all chemo is equally awful. And I think as chemo goes, thinking in the spectrum of lung cancer and even broader across cancer, Pem-Carbo is one of the gentler regimens available to us. And so I also am quite partial to it. It may make me a little bit old school, but I do add bevacizumab, otherwise known as Avastin.
It's like it was a plant. Do we any benefit to adding?
So, prior to our more modern era, there was data for that triplet. It was once in vogue, but there's also some non-randomized data suggesting, and I do mean to use a weak word in saying suggesting, that it may be more helpful in patients with EGFR mutants than other patients. But I think we would be remiss if we didn't mention the quadruplet of carboplatin, paclitaxel, bevacizumab, and atezolizumab. I see the smile to laughter, and that was kind of my reaction as well to this regimen. It feels like a lot. It's 4 drugs, going from targeted therapy to 4 drugs. I will say that I bring it up with patients, kind of hoping they don't choose it, and a shocking number do. And what's the two good things I would say about that regimen are, most importantly, it's the only context where we have a hint of immunotherapy clearly helping an EGFR mutated population. I wouldn't call it definitive, but it at least gives a patient that chance in some legitimate way. The other is that once you're done with your 4 cycles, you don't have to continue any cytotoxic. It's still infusional, but you're on to atezolizumab and bevacizumab alone without any chemo in there. And for some patients, that can be nice, getting that.
Yeah, I agree. I mean, I think it's, as you say, if we're going to use immunotherapy, I think using it in combination with chemotherapy feels better than using immunotherapy alone. I will say that, I've discussed it with patients, although I have been hesitant to use it. I think the toxicity of that 4-drug regimen is not insignificant and really has to be weighed carefully. Neuropathy, hair loss, which is something that we see much more with that regimen than we do with pemetrexed-based regimens. Those are important side effects and have an important impact on quality of life. I also personally worry, patients who've had brain metastases, I think this is a big issue. And for patients who've had brain metastases that remain controlled on osimertinib, I worry very much about stopping the osimertinib and moving on to the immunotherapy, where if we do see that the osimertinib was helping to control that cancer in the brain and we start to see some growth, we're a bit worried about adding back the osimertinib if patients have had immunotherapy. So those are things we have to weigh. It's obviously a patient-by-patient decision. It really depends on a lot of factors. The sites of disease, patient preference, I think very, very importantly, how well they are and how we think patients would tolerate that regimen, but certainly is something to consider.
So you bring up the idea of continuing OC with chemo in select patients. What about continuing OC past progression? Figuratively putting your finger over a problem on the scan of it and watching it.
I think we do that all the time. In the interest of time, I didn't go into that in great detail, but absolutely, I think, progression comes in many different varieties and forms. And there are some patients where progression might mean a few millimeters of growth and a few lung nodules that is not causing the patient any symptoms and is not likely to cause them any symptoms in the near future. Patients are feeling very well, they're tolerating Tagrisso well. And in those situations, I think you can actually squeeze a lot more goodness out of the osimertinib before you have to switch therapy. And ultimately, the way that I explain this to my patients is that this is what it's really all about, squeezing as much kind of juice out of each treatment as you can before moving on to another one. And even though we see quote unquote progression on a scan, I think the question I really try to ask myself is this clinically significant progression, or is it likely to become clinically significant in the near future? And to me, those are the reasons to switch.
My practice is identical. I've been shocked at how long I've been able to watch things post-progression in select patients. Philosophically, I think what we care about is how long our patients live and their quality of life during that time. And if the cancer isn't threatening that, then I don't really have such a problem.
I will say, sometimes it can be a hard thing for patients. Once you start to see some growth, I think understandably that sometimes it's really hard to say, we'll just sit on it and watch it, but I think with close surveillance and careful follow-up, that can be done very safely and well. And I think, it's something that is absolutely worth discussing. And I think the other thing too is local therapy. So radiation or other treatments, if it's a single solitary site of progression, that can also be another way to kind of squeeze more time out of a particular treatment that hasn't completely failed, but maybe just, isn't working quite as well in one area.